today.
Great. So welcome everyone. Thanks PMD Alliance for continuing to host. And I think it's getting cooler across the country now, in the US at least, and except for our West Coast, which continues to be quite warm and some fires brewing, I think, in some places. So hopefully everyone's staying safe, and I'm excited to continue to connect this way. We'd love to be connecting more personally, but we're physically distanced, but socially and virtually connecting this way, which we encourage you to continue to try to do as patients and as people in the world, to try to connect with each other. So today I'm excited to bring you one of my friends who has just been doing some amazing work in advocacy and activism on the other coast. Normally, Jill and I would have met up in a meeting or somewhere in the last 6 months, but we've been trying to keep the dream alive as working with mothers and
Yes.
working a lot of us, and working with telehealth and all the fun of these virtual modalities, which are, I think, brilliant in many ways, but can add stress, I know, to a lot of our patients and families across the world. So I'm excited to introduce Jill Farmer, out from currently in New Jersey, but working in Pennsylvania. You'll have to teach us about the geography again. It's a little
It's okay.
But yeah, so Jill has become, a friend through the Women in Neurology group, and we both are movement disorder specialists, and have been really talking a lot through the pandemic about issues of, getting coverage for telehealth, which I know a lot of folks have been enjoying the benefits of using this modality to be able to not have to leave their homes and to stay safe. But behind the scenes, Jill has been working tirelessly to try to keep our reimbursement happening and working on a national level to help neurologists and I think people in general to keep this modality alive and paid for. So welcome, Jill. Maybe you can tell us a little bit about yourself, your background, teach us a little bit about what drew you to neurology and then Parkinson's disease.
Absolutely. So hi, everybody. Thank you so much for having me on this conversation. It's such a fun space and platform, and I'm really looking forward to it. I am a movement disorder specialist. I did my training at Georgetown, and afterwards moved from Washington, D.C. back to where my family is from, which is in New Jersey, and have worked in New Jersey and Pennsylvania. I'm right on the border, so that's kind of how the dual state geography works. And I have been in both hospital-based practice and private practice and academics through Drexel. So I kind of have had a little taste of everything. And I fell into movement disorders, actually. I was going to do a fellowship in cognitive behavioral neurology through Georgetown, and I went through all the work of getting a fellowship set up and finding funding. And then I was out on maternity leave with my first child, and the person that had the funding decided that they were going to move on to another institution. And they said, well, you can come with us or you can't, and then you're out of a fellowship. And I was in no condition to move, and my husband had just started a post back at the Army Research Lab, and he was in no condition to move. So while I was out on maternity leave and all, sleep deprived and hormonal, one of my favorite attendings from residency called me up and said, we have a space in the movement disorder program, and I can tell you that there's a lot of overlap between cognitive behavioral and movement disorders. And I said, I'll take it. And I jumped on it, and they say things happen for a reason. And it's true, because it is the absolute right space for me in neurology. I love my job. I love the working with patients and the disease state and process and the chronicity of it. So you develop long-term relationships, and there's a lot of common sense in our practice of medicine for Parkinson's disease. And there's interventions that we can do both medically, surgically, and behaviorally. So it hits all my sweet spots, and I've loved it ever since. And I'm going on almost 10 years now out in clinical practice, which is not very long, I know, but to me, I'm like, wow, I can't believe it's been 10 years already.
Wow. Well, you're very resilient, Jill. I didn't know that story about you and the fellowship, but you've also had some, I guess, bumps or twists in the road with your practice as well. Maybe teach us a little bit about what happened with the Drexel situation and kind of how you doing what you're doing now.
So when I have my clinical course with my practice has been an interesting one as well. And even though I'm almost 10 years out, I've actually been with the same group of docs from the very beginning, right out of fellowship, but we've worn 3 different hats. So I've come from, when I first joined out of fellowship, was a hospital-based practice, and they wanted to expand into more research. So they tried to partner with an academic model. And in New Jersey, in the East Coast, we're pretty dense academically. I mean, you have New York, you have Philadelphia, you have programs even within New Jersey that are hospital-based but linked to academic institutions. So there's no want for it, but each one kind of varies in its flavor and its size. And Drexel happened to be a smaller neurology program, so they decided that would be great. We can partner with Drexel, and we were going to do that, and it was all looking like it was going to work out just fine. And then the politics and the business of medicine get in the way. So there was a, sorry about that. So there was a schism that happened, and then I went to Drexel with the same group of people, the same neurologists, the same neurosurgeons, and we built up the program, the movement program at Drexel. I was the first movement disorder specialist they had, and it was wonderful. And then again, the business and politics of medicine got in the way, and the hospital that was linked with Drexel, Hahnemann University Hospital, a very famous hospital, had been slowly declining because of the different payer mix and the insurances that were teased out in the Philadelphia area, and eventually went bankrupt. And when they went bankrupt, they had to break from Drexel University, and they dissolved the entire Drexel College of Physician network. So even though Drexel still has a medical school, they no longer had any clinical faculty because they dissolved the physicians network that they had, and everybody sort of dispersed to different areas, different other academic hospitals in Philly, different community hospitals in Philly. And then that's when the same group that I was with at Capital and the same group I was with at Drexel decided to form their own group and become a private practice. And so that's where I am now. So yeah, 10 years, same location, 3 different hats.
Wow. And then now with the pandemic, doing a lot of things virtually. So tell us a little bit about your practice and kind of what it's involving these days, and kind of how you've embraced in many ways the telehealth.
So I had always been a big proponent of telehealth. I got a grant prior to the pandemic through the Parkinson's Foundation to, I tried to be creative, and it worked because it was a community outreach grant. And usually that's for things like, support groups and classes and stuff like that, that they can help financially support. And I said, well, does access to telemedicine, which then would allow patients to get greater access to a specialist that they might not otherwise have, count as community outreach and access opportunities? And they said, yeah, I think it might. So I ended up getting a grant for that through the Parkinson's Foundation, and was working with one specific location. So I had seen patients at a physical therapy site called the Parkinson's Life Center, which is in southern New Jersey by Atlantic City. And geographically speaking, that area does not have access to a ton of specialists or a lot of academic institutions. Even though they're not too far from Philly, they're just far enough where it just makes it difficult and cumbersome to get to. So I had done a support group down there, teaching and educating on Parkinson's and DBS and all of that sort of thing. And I saw that the patients really needed to be seen and followed by a specialist. So I asked where I was in practice at the time, which was the first place, Capital Health. I said, can I set up a clinic down there, like one day every 6 weeks, just to kind of allow them to have access and opportunity? And it was about almost a 2-hour drive for me each way to do it, but it was only once every 6 weeks, so it wasn't so bad. And the need was so great. Then as I transitioned from Capital to Drexel to other places, it just got a little harder to coordinate. And so I wasn't able to keep that clinic. And then this opportunity for the grant came up. So I said, this will be perfect. So there's different ways to do telemedicine. And the model that I had for this grant was a particular endpoint. So an endpoint would be where the patient is seeing the doctor on their screen. and the remote site for the doctor could be anywhere. So in this model, there was a fixed computer that was dedicated to telemedicine at this physical therapy location. Patients would leave their home, go to this physical therapy location, which was much closer to them to get to, and then I would see them remotely via that computer. And it worked really well. We were doing anywhere from 3 to 6 patients a week that way, but it was, again, a very small patient population because it was fixed to either patients that I had already seen or patients that just had access to the physical therapy program, and it worked. And that was in 2019, early 2020, and then COVID hit, and then telemedicine became available to the masses, and so it was the need for that program became moot. But it was a good jumping off point, and it was also good because it showed my practice how easy it was to elicit telemedicine. The neurosurgeons had known about it because neurosurgeons use telemedicine often for stroke and stuff, like our neurosurgeons anyway. They're the ones that run the stroke calls because they're interventional neurosurgeons. They can go in and pull out clots and stuff like that. So they use telemedicine in the hospital all the time. Someone comes in with stroke symptoms. They say, how recently did this start? Is it under a certain number of hours? Okay, we can intervene, and they'll speak to a neurosurgeon or a neurologist via telemedicine that way so they can elicit very time-specific interventions to help prevent the results of the stroke from being permanent. So they were used to it in that regard, but they had never really thought about it or worked with it much on a chronic basis for follow-ups and establishing new patient connections and things like that. So it was helpful for them to see how it could be utilized that way. And then when COVID hit, it was very easy for them to adapt to the larger practice as a whole, to get all of the neurologists that are on board and the neurosurgeons that are not just the interventional stroke neurosurgeons to utilize telemedicine on a more regular basis.
Wow, that's amazing. So you really had this pilot idea. That's kind of cool. We have something similar at the VA historically called where patients will go into a sister, like a little remote VA site, and come in, and it's like what they call a CBOC, and they'll have telemedicine from that location to another location. One of the glitches tends to be that you need a person at that place to be able to run and introduce the patient and bring pull it up and possibly examine the patient remotely if things are needed. Did you have somebody at the physical therapy place that was able to interface with you?
I did. So it wasn't, she was just an admin person at the physical therapy place. She basically brought the patients back from when they checked in at the main desk, and then brought them back into the visit to make sure that the connection was good and that we can hear everybody okay. And that was about it. The big change that happened with the onset of COVID was that initiating site requirement was lifted. So you didn't have to, the way that insurance was demanding that it had to be conducted to get coverage was that the patients had to be at a particular site, whether it be an office like a doctor's office or a physical therapist office, or inside a nursing home, or some place where there were these other individuals that could interact with them to make sure that either they were getting vitals checked or they were making sure they were logging on okay. But with the onset of COVID, that was lifted. So now patients were able to do telemedicine directly from their home, which was a huge adaptation, and not just because of the convenience factor of not being able to have to travel anywhere at all, but also because of the reimbursement factor. So when they started to chip away at some of the restrictions, and that being a major one, that was huge. That really made it so that telemedicine could be incorporated across the country, across specialties, so much more easily.
That's really interesting. So tell us a little bit about how you've been incorporating, I mean, presumably like all of us, you kind of went from that model to then needing to do it from your home, from a laptop, with your kids around in the space as well, because you have children, and are running this clinic basically from your porch and now inside by the fireplace. So tell us a little bit about that transition as a clinician for you.
Mhm.
And I know that you work quite closely with the Women in Neurology group and have been doing some advocacy and even some surveying of how much
Mhm.
time people are spending with writing notes and things like that. So
Mhm.
what is like your average clinic that's a telehealth clinic like? How much time do you spend with your new people? How much do you
Yeah.
spend with your follow-ups? And maybe give us some practical ideas of what that looks like for you.
So I really tried to make it like a one-to-one transition. So my in the office, my new patients are 60 minutes, my follow-ups are 30 minutes. I provide a lot of samples, I have a lot of patient ed materials and that sort of thing. So within the first few weeks of transitioning over to remote medicine, I went to my office and I essentially cleared it out and moved everything that I had in my office at work to my dining room and my kitchen at home. So it was, I mean, I must like the amount of samples that I had, it was unbelievable. And the amount of, Parkinson's Alliance and all of that and Parkinson's pamphlets and everything just taking up space on my bookshelves, huge. So I tried to make it so that when I was speaking with a patient, I would have all of the resources that I would have at my office accessible so that when I was done with the visit, if I was like, oh, we were going to start this medication, or you had questions about nutrition and Parkinson's, here's this booklet and here's this pamphlet, the difference was instead of being able to hand it to them, I had to mail it to them. And that wasn't so bad. I live in a very small, not a very small town, but I live in a town, a borough. Everything's within walkable distance. There's a post office in walkable distance. And honestly, like in the beginning days of the shutdown and the quarantine, it was my weekly outing to go to the post office, all masked up and everything, but to be able to get out and send my patients the materials and the samples that they needed. So the access of being able to provide the same level of care, I really didn't find was much different, whether it was in person or with telemedicine. I also didn't find that it was any less intimate, especially with patients that I already knew. I think we already had a rapport, so that was an easy connection to make. But even with new patients, it wasn't, I didn't feel like because there was the screen that it was an artificial barrier that I wasn't able to make a connection. And I say this all the time when I talk to people about telemedicine. I think if you have a good bedside manner and you have the ability to connect with people, you'll have a good screen side manner too. You'll miss the ability to put your hand on a shoulder or to hold a hand or put your hand on a knee. I'm a touchy feely person, so that is just my natural way. I miss the hugs. I do miss giving patients hugs at the end of the visit, or getting a hug at the beginning if I haven't seen someone for a while. But even despite the tactile connectivity, like you can still make the connection because I'm never as face to face with someone as I am with telemedicine. Like I'm sitting in front of somebody, but when they're on a screen, I mean, their face is prominent and their face is huge, and you can really see more subtle clues than you might even see if you're just sitting in the same room with a person. So like there's trade-offs between the two, but I really honestly have not found it all that limiting in any way as far as being able to elicit the responses that I need to conduct the pertinent parts of the exam that I need. You can't do everything, but you can do a lot, and being able to have that connection. There are other barriers as far as sometimes I can't hear and when it doesn't connect right away, and if there are problems with the speed of the internet connection and all of that. But you said I was adaptable. I am adaptable. Like you kind of just roll with it. You let it. You work with what you got at the hand, and if it all goes to hell in a handbasket, then you just call them on the phone, and you at least get some information that way.
Yeah. Yeah. And have you been back in the office at all, or are you doing everything remotely?
No, I'm 3 days telemedicine, and I'm 2 days in the office, and those are predominantly reserved for procedures. So I do Botox injections, DBS, duopa programming, all of that stuff. And then the follow-up that I feel like I need to see. So like I said, well, I can do pretty much what I need remotely. If there's something on an exam, especially for a new patient where I'm just not quite sure and I need to be able to check cogwheeling or really see the amount of slowness or the stiffness or the rigidity, then I'll just have the patient come in, and it's not as extensive a visit because essentially it's a follow-up then, but it is, I'm able to enhance whatever I needed to do from the initial new patient visit in the office, and then do that rather quickly and then come up with a plan of care. So most of the time it's procedures, but there's the odd new patient or follow-up that comes in as well.
Yeah. I mean, we've been going in a little bit at the VA side, and it is stressful because we're all, I mean, I'm a very touchy-feely person too, and it's hard to not have that
Yeah.
physical connection. Even during the pandemic with social distancing, we're wearing masks, and so you
Yes.
see, this part of me, and there is a lack of connection that way too. Because I think when I'm in person with somebody and I can't really see their entire face, they can't see mine. There's a bit of a disconnect as well there. So
Yeah.
I think we all look forward to the days when we're going to be able to go back and see each other and touch each other and have that
Yes.
connection. But I think in the meantime, I think we really have to figure out how to maneuver with the current barriers and
Yep.
restrictions that we have. Have you found, and I know, Jill, that you wrote a blog for us as well with Mike Open, and you had put in some very practical tips in there. Maybe you could help, because it's mostly patients and caregivers and people who, care about Parkinson's patients, living with Parkinson's patients and things like that. Maybe we could spend a little bit of time talking about sort of your practical tips when do you have a handout or something that you send patients, or how are you kind of helping them make the most of these telehealth visits?
Right. So I don't have a handout specifically that I send. I know that our staff does spend time calling patients. In the beginning, it was transitioning them from an in-person visit to a telehealth visit. Now it's just being scheduled as a telehealth visit outright, because we've been at this so long. We're no longer taking the schedule that was already in place. Now we are actually, working with a new schedule because it's been, 9 months, 7 months that we're doing this. I know when they schedule the visits, they have a handout or a checklist that they'll go over with the patients. They'll talk to them about their web connection. They'll talk to them about the web browser that they use. They'll talk to them about the link that they're going to be sent. They'll talk to them about checking their spam, because sometimes the things that we send don't come to their regular email, but goes to their spam folder. So from the onset, if you are scheduling a new visit or a follow-up visit with your doc via telemedicine, if you don't get a link, and they said they were going to send you a link, always check your spam folder first, because you'll be surprised at what ends up in there. And then move that to your regular inbox, and then that will then make that email address known and recognized, so that you don't have to worry about it going to the spam folder again. And then the internet browsers matter. And I am by no means a tech person. My husband's sitting in the other room right now, and he's a computer engineer, and he's probably laughing to himself as I'm sitting here trying to talk to you all about what to do with the internet and connections and the different platforms that we do telemedicine and whatnot on. But it's the stuff that I've learned. The internet browser matters for whatever reason. It does. So if they tell you when you're signing up that you should really have Chrome or Internet Explorer, and use that one, make sure that if you can't install it yourself, that may be speaking to someone in your family that can, if that's not an automatic browser that pops up for you on your computer. It also, if you have depending if you have a Mac or a PC, I know that Mac is Safari, and not everything is as compatible with Safari as some of the other ones. So, but you can install Chrome on a Mac as well, because that's what I have for our platform that we use, DocSeeMe, and it works better. It always works, but there are just some of these little things that get flubbed up for whatever reason. So just try to listen to what they tell you when you're setting up the appointment. And like I said, if it all goes wrong and you can't figure it out, one of the reasons why this was so widely adaptable so quickly was because phones now have the ability to video chat, and you can always just opt over and switch from a different, if they're telling you to use Doxy or they're telling you to use Zoom and it's just not working, say, but I have an iPhone, can we just FaceTime? Absolutely. Or I have, if it's if you have an Android, whatever their equivalent of FaceTime might be is, then you can just switch over to that. And that works fine. And it's, again, that adaptability thing, trying not to get flustered, knowing that you have the time to make the adjustments that you need to do is important. And there are times like the first 5-10 minutes of the visit are just troubleshooting this with patients, even if they've gone through it all with everybody from the office before. And I can appreciate that. And I don't get frustrated because, like I said, I'm not a tech person. So I get flubbed and flustered easily too. So it's if I call them because they didn't log in and they say, I never received the link, what I just said, look for your spam folder. Oh, there it is. Oh, I never got it. Then I'll resend the link while I'm on the phone and wait until they get it and then connect that way. So it's there's a little bit of extra effort on those parts, but it's just a learning curve. And if you do it once or twice, usually the rest of the visits are just fine.
Yeah. I feel like there is sometimes anxiety with some of our patients, and they want to do it all right and not disappoint me, and then they sort of freak out. And sometimes there's like they're more dyskinetic or they're trembling, and I'm like, it's okay. Let's take some deep breaths together. Chill, it's fine. It's stressful for all of us, but it'll work out. It's this is not like a life-threatening thing that has to happen. And if we can't do it today, we'll try to. The good news is I don't have to drive back to my office. We can try to reconnect later.
Exactly.
Sort of taking that, taking a few deep breaths, taking a bit of a chill pill, just okay, it'll all work out in the end. And after all, the phone is going to probably be fine as well. And if we can't get all the, the information, we can always bring people in if we need it. So there's been a few questions and comments. So one is, how do we do the shoulder pull, or, we're placing that with telemedicine. Roger asked that. And then Cookie likes your screen side manner comment, but the worried that her doctor is more cold and reserved. So, so I don't know, maybe you want to speak to those two things. So how do we do the pull test? It sounds like.
So the answer is you can't. You can't check cogwheeling and you can't do the pull test, but there are other ways to assess balance as well as rigidity. So oftentimes, I mean, how many people have been asked to walk for their doctor, especially like for a movement disorder visit? So subtle changes in arm swing, stride length, things like that can all give us a hint as to the rigidity or the tone of somebody without actually testing cogwheeling. The balance test for the pull test, you can have people, check their balances by standing on one foot, things like that. The retropulsion, you're not going to be able to elicit. And I would not recommend having a family member try it so that you can observe it, because I don't want anybody falling or falling into a family member. The reality is those two parts of the exam are really not necessarily going to change the overall clinical management of what you are looking at, because you're looking at the big picture. So if you're telling me that your balance is off, I don't need to see a positive pull test in order to make a change. I'm going to go by what the history is of what you're saying, and about other things like, oh, when I go to stand up, I fall back into my chair, or I try to get out of my car and I fall back in, and that kind of stuff is going to give me that same information as if I could actually do the pull test in person. As far as the, having somebody that's a little bit more cold and reserved, we can't fix other people's personalities, unfortunately. It's kind of where they might be in how they are conducting their clinical practice. Not everybody has to be touchy-feely, and if you're getting good care and you are, feeling good with the treatment plans that you're coming up with, then you try to make up for their lack of warmth by being overly, warm and charming, and see if you can get them to crack a smile.
Yeah, I think it's all individual. I think, there's no one doctor for everybody. I think, people that click with us may not click with others. It's sort of just, it's a bit of a stylistic thing. But yeah, so there's also a few other comments here that Marv feels some pressure knowing that the doctor's time is valuable. And I appreciate that. I really do, as well. But it is, having somebody flustered and freaked out is not actually that good for us either, because then we're like trying to calm people down so that we can get to the sort of meat of the visit and kind of and be able to do an exam without, too much stress on board. So I think, it's all, we're all learning. It sounds like, everyone has to just sort of go with the flow a bit.
It is.
been a couple of other. So Pop Pop wants to know about what is cogwheeling.
Okay, so cogwheeling is, I don't know if when you go to your doc, if they kind of hold your hand and move it around like this, and then maybe they ask you to open and close one hand while they do that with another hand. What we're looking for is an increase in resistance to that move that we're doing. And cogwheeling is part of the clinical features of Parkinson's disease. It's an indication of tone. It's an indication of stiffness and rigidity. So when we feel that, that lets us know, oh, while you might not look like you are overly stiff, when we're testing it in a confrontational way, we're bringing it out a little bit more. So it just gives us more information about that part of the clinical cardinal features of Parkinson's disease. Tremor, slowness, rigidity, and postural instability are the four things that we kind of hold as the pillars of what we're using as diagnosis.
That's great. And then I think just looking at the article, and we'll post that, maybe Andrea, you can post that with on the chat here, Jill's article on my book and my blog. So a couple of other things that you mentioned about connectivity. So making sure that you're as close to the router in your house as possible. And then making sure that you see some good bars on your device or whatever is what you wrote. You talked about the closing things on your computer, so that you're using the maximum amount of the internet sort of space or whatever and power to do the application. So if you can close applications, and possibly if you have a family member to kind of walk you through some of these things, if you're having issues with understanding some of what we're saying, it would be helpful, because all of these things I think are very practical tips and are on your blog. You talked about the Chrome as maybe the go-to, the FaceTime as a backup, making sure the volume is fully up is something else that you said, which is a great tip as well. And then the lighting, maybe you want to speak to the lighting?
Sure. So I'm actually not following my own tip right now, but that's because it's a cloudy day outside. But try not to sit with in front of a door or a window, because it puts you in shadow. So you will be dark to the person that's observing you, and it'll just be harder to see. So usually sitting in front of, a plain old wall or something that doesn't have a light behind you is more helpful, so that we're able to capture as much as we can subtly on that exam, so that we can see your hands move, we can see your fingers move, we can see that arm swing when you walk. The other thing about closing the other browsers and windows that might be open that's important is, when part of the things that lead to being frantic is, oh my goodness, I can see you but I can't hear you, or oh my goodness, I can hear you but I can't see you. And you've done all your pre-test calls and everything worked like 2 seconds ago, but it doesn't work now. That might be because one of the other things that you have open has access to your microphone on your computer or your camera on your computer, and the computer, as smart as it is not smart enough to do it in 2 different things at one time. So having everything closed before you start kind of takes that potential stressor or variable out of the picture.
That's a great tip. What other things? I think there's a few practical things that I've found, like, for example, having pencil and paper, or something like that available is something. And then another thing is just having medications right there, so that you can kind of go through them. Because I know, all the things that you might bring to my office, if you could just have near you, because we don't want you roaming around your house trying to collect all your pill bottles and stuff like that, So that's been another thing. Any other sorts of things like that we're forgetting? I mean, I think those are and then maybe having a family member there just to facilitate, I think, is also pretty helpful. So have you, Jill, had like a telehealth visit where the patient is there and then another family member calls in from a different place?
I have. I've actually, that has been one of the nicer things about the virtual visits. We've been able to not only have patients and family members who are not in the same house or facility as the patient connect, so it's been almost like a 3-way or a 4-way call, but for patients that are in nursing homes, who would otherwise not be able to see family members or have access to family members, like, they kind of connect over the visit. And that's been a sad but nice sort of byproduct of all of this. And it's been really helpful because I can tell you, and I'm pretty sure Dr. Subramanian can say the same, if we have patients that are coming from nursing homes and they don't come with anybody except someone from the nursing home that is unable to provide a history or unable to give us any information other than the packets of paper that they come with, it's a far less productive visit than it would be if someone was there to help fill in the blanks. So that's been really helpful.
Yeah, and we've had, actually with that, we have had some video visits to the nursing home where the nurse who actually administers the medicine is
Yes.
right there, which has been kind of cool. And they're able to actually pull out the paper and show us, on the thing.
Yep.
And I did have a very touching moment yesterday where I had a patient on telehealth with from a nursing home, and then her daughter was there and her granddaughter walked in the room, and they hadn't actually seen each other in months, and I actually convinced them to stay on. I was like, I have to go, but can you guys stay on and just let them kind of connect? But it's such a sweet and sad moment of our reality right now. So yes, I think it is sort of a beautiful thing that we do have technology and can connect people sometimes just using these virtual visits. And I think if you do have family members that are out there that could give more information, of course, there's limited time. So you want to make sure that you're not teaching the family member about what's been going on either. I think it should be something that can contribute to the visit, but I think it's helpful to have, family member possibly weigh in on the visit, as well, and use the time, efficiently, so that we're not having 7 different conversations with a bunch of people that are, arrived. But I think if it can be adding to the conversation, I think it's actually very helpful to get things implemented as well, and stuff. How do you give patient instructions to the patient?
So we don't have a portal, but I made my own portal by creating a do not reply Gmail account. So the email will say, which is completely made up, it'll say do not reply.jfarmer.gnineuro@gmail.com. So I set up a new account, and after the visit, I will email out a summary. Trying to be as HIPAA compliant as possible. I won't put in a greeting or anything like that. I'll just say, it was a pleasure seeing you via telemedicine today, so that there's nothing identifiable in it. And that then we'll kind of list the discussions of, what med to start or what websites to look at for virtual programs and things like that. But that's how I've been providing instructions after the fact. And then we'll just copy and paste that into their chart.
Great. That's amazing. You're very, very out of the box thinker. I'm proud of you. Because we have to think about these sort of ways to go around, right? Because the HIPAA compliance and all these different healthcare systems. But at the end of the day, we want to try to, get the instructions to people.
Right.
Sometimes also I'll type in the chat and then I'll teach people how to do a screenshot so that they can have, the information if we're doing Zoom or something like that. But yes. So somebody wrote, you are a real go-getter. Mailing Depot, IT help desk, not to mention the medical training. Yeah, and somebody, Michael says, I found it helpful to have a prepared list of my current concerns and symptoms, so I don't have to rely on a memory. So absolutely. So I think having the pills right there with, with the maybe typed out so that people know how you're taking them, and then having, your, top few things that you want to cover, I think is very helpful, because the visit does go by very quickly, and sometimes there's other distractions. But what other things that I found is sort of interesting, things that we're able to observe, is actually the people in their own homes with their environment. So, if it means watching them walk with all the little dogs in the room,
right,
dog, or the suitcases that they have piled up in the background, or all their sports equipment. I think it's helpful for us to physically see patients in their own environment. And there's been a few safety things that I've been able to kind of troubleshoot just from, watching people on video. So, so it is cute. One of the things that you and I were talking about before this was, missing our hugs and touchy-feely stuff, but also we both have patients that are remarkably good at baking, and it sounds like, and I look forward to the cookies and the cakes and things that are brought. So I do miss that. And one of my patients actually was, the husband was enjoying the apparent pie that was baked for me. Oh, Dr. It's so bad that we can't see you and bring the pie to you, but it's really good. Trust me. And I was like, okay, thanks a lot. But, so there are those things that we do miss, but,
Yes.
we are missing that sort of physical connection, but I think this connection is really tremendous that we have this at least. A couple other things, because you have been such a go-getter in the sense of thinking outside the box. Maybe, Jill, you have some ideas. One of the chats that came up, we were talking about unmet needs and disparities last week. There is a sense that people in some of the age groups of Parkinson's in this country, that is, at the forefront of, the developed world in some ways, have in our current healthcare system, do not have access because of where they live. Either it's rural or they don't have the funds to pay for internet or a device to use the internet. Do you have any thoughts on that and how to kind of think outside that barrier and what we can do?
Right. No, that's a very real issue and concern. And I don't have anything specific to say other than there are resources through the different internet providers that can allow you to have waivers or better access. I know about this more for education than I know for medicine, but I have to imagine that there has to be overlap between the two areas of need. So I know for like my kids' school, if there were issues with being able to get internet access, you could apply for a grant or a waiver through Comcast or through FiOS or through different things like that, different companies that show your need, show that you're using it for education, and something would be done, whether it would be provided at cost or it would be done through the school, where the school would then give you access through some of their platforms. And I think something similar would be done for medical needs. It's not something that I've looked into a ton, but it's where I would start.
Yeah. And I don't know, PMD Alliance gang, if you are aware of anything, maybe you could put it in the chat if there are some things. Presumably anyone who's on this program has surmounted that barrier. But I think,
Right.
one of the things that I've been very attuned to from day one of this pandemic is who we're not able to reach out there. And there are some people on the phone with this on this recording as well, and seeing some people. We'll watch it later on YouTube. But I think, thinking about this in a global way, one of the things that came up was having universal free internet, as sort of basic requirement in the world of, our country at least. And then having, but, even when people have the ability to have internet, in rural places, it's just not reliable. So
Right.
having really a good connection somehow, I don't know, through satellite, or I don't know how it works. I'm not that techie either, but there should be ways to surmount this. And I think you're absolutely right. If there are places that are able to give waivers or funding to cover this, I think that's a really, important place to start for some of our patients who just can't connect, because ultimately, if we're really talking about access to the people that need it the most, it doesn't help to save, drive time for somebody who's well insured. Yes, that's a benefit, which is a lot of what our outcomes show in telehealth studies. But if people who couldn't access a movement disorder specialist in the first place are still not able to access physicians or neurologists because of where they live, and now the pandemic has made that even harder, given the fact that they're only able to access through telehealth, and then actually we're doing that population an even bigger disservice, I think. But kudos to you for driving 4 hours, it sounds like, just to get specialty care in that Atlantic City region or whatever. That's an undertaking, especially having children in a family. But I think, those needs do exist. And we've talked a little bit about, how to address those needs as well, with educating more towards primary care, doctors who might be seeing patients in the community, perhaps having mid-level or different types of other nurse practitioners, PAs, things like that, be able to interface with this as well, to really get the patients who need it care for Parkinson's that's universal. As a group, you guys have neurosurgeons, it sounds like, and then I know that you have, I saw something about you trying to hire somebody recently.
Yes. We're
Yeah.
trying. We're
So,
trying to hire a second movement specialist. I'm the only one in the group right now, but yeah.
and are there other allied providers like social work, anyone else, nurses, things like that, that are part of the care
Right.
paradigm?
So there is MAs. There's one nurse for that kind of just oversees stuff more on the neurosurgery side than the neurology side, and we don't have any nurse practitioners. We do on the neurosurgery side. They do have physician's assistants, but they're more utilized in the hospital, like for rounding and stuff like that, but not so much in the outpatient setting. We did get the go ahead to hire a social worker, so if anybody on this call is in the New Jersey region and knows a social worker that's looking for a job, please get in touch with me, because it has been that was like my big win of the pandemic. Like, not just having everybody transition over like to telehealth and having it go smoothly, but to getting everyone to agree that yes, we do need a social worker now more than ever, because so many of our patients have everybody was kind of cruising along okay, and then towards the end of the summer everybody hit a wall, and a lot of that wall was social stuff that needs to be addressed, that I do my best to try and address, but I'm not a social worker, so I don't know all the nuances and the ins and outs of access to certain resources in the community and things like that. So I think everybody agreed at that point, yes, it's time, and so yay, we're looking to hire and bring that very key personnel on board. But one of the things that you were talking about with disparities in access is this is something that goes to the continuation of telemedicine. Is telemedicine, we think because it has tele in it, is video, but it doesn't always have to be. Phone can count as telehealth and telemedicine. And so one of the things where they're going to start to look to reduce and chip away at some of the access that's been granted is to take away just the phone call being reimbursed as a viable means to the visit, to an office visit. And I think everybody would agree that it is not the most ideal, but it is sometimes practical and can be quite useful. So one of the things that we were talking about before we hopped on was patients have a very strong voice. So there are lots of things that are going on right now where national groups like the Michael J. Fox Foundation and Parkinson's Foundation and that are looking for stories about how patients have responded to telemedicine, if the good, the bad, and the ugly kind of thing, ways to get patients to reach out to their representatives, not to do anything that is, you know, too much heavy lifting, but there are websites, and I think they'll be posted in the chat, where you can sort of just click on the website, put in your zip code, it will tell you your representatives, and there's form letters already made, and all you have to do is click send. It's more for the numbers that they get in response to these questions than it is the actual content of what are in those letters, but feel free to share personal stories if you have them, because if they can see that there is a critical mass of patients that are demanding that these that this access continue, that goes a long way, sometimes even more than what the docs are saying as a need and a necessity. So especially because access can be an issue with video and can be an issue with internet connection and whatnot. Phones are ubiquitous. So most people do have access, even if it's on a limited payment plan type of service that they have, they do have access to some sort of phone, and that is something that should be continued as it's been through the public health emergency.
Yeah, absolutely. So a couple of comments here. One is that is talking about going to the public library possibly as a place to, I mean, I guess it's a little hard because you're talking about your own health at a public library, and trying to connect for a televisit is probably a little awkward. I don't know and I don't know how many of the libraries are actually open right now, honestly, for internet access and things. I would think that because they're indoors, it might be somewhat restricted given the pandemic, but that might be an idea. the folks here, Andrea and Anissa, have written about www.everyoneon.org, which has a directory of low-cost internet access and
Oh,
hardware discount programs. And then Anissa has something from dailycaring.com, 7 sources of low-cost internet for seniors. But I do think that as organizations that are running advocacy groups, that this is something that I think makes a lot of sense to try to figure out low-cost ways for seniors to connect. It has to be part of the dialogue, because if most of our patients who are Parkinson's, living with Parkinson's, are, you know, above a certain age and don't have access, and because of cost or you know, other things, I think it makes a lot of sense to try to you know, try to help with that. And then Andrea also wrote about the Michael J. Fox Foundation action alert to tell your lawmaker people with PD need telemedicine. So there's a website here, and we'll link all of these things and anything else, Jill, that you want to link
sure.
for the patient voice, because I agree. I think just so people know, Jill, literally day one of pandemic, I called PMD Alliance and started these virtual work groups through the social distancing series, but Jill was, in the meantime, trying to advocate for getting telehealth reimbursed on a huge level, and literally spent, I think, I don't know how many hours you spent trying to reach out to every state and have every state's representative sign some sort of, you know, huge thing that went to some of these people that make decisions around advocacy at a state level, that then went up, you know, on the national level to help with this. So, you know, I think there are, you know, ways that we can look at problems and try to create solutions, and Jill has totally been part of that, and actually working with the Women in Neurology group, who we've had a number of members of, and Catherine will come on in the next week or two as well, to try to, you know, just align through a common cause of being women, and thinking about advocacy to see if we can kind of really you know, work around this sort of thing. You're also a community organizer, lobbyist, apparently. Is that true?
No, well, not by title, by some action. So
Okay.
yeah.
I mean, I think we need people like you, Jill. You know, I think, you know, getting it done, you know, thinking outside the box. I think a lot of people are like, oh, well, I don't have a way to communicate with my patients through the health record. I guess there's no way to send a visit summary. But, you know, thinking about that Google thing, that's so smart. You know, these little things that we're all doing, you know, really probably need to be put in a central place so that doctors can access it. And that if patients go in and say, you know, can you email it to me this way? You know, I was on this the Alliance program and they showed me this way or whatever. I think it would just be a great way to, you know, the doctors are also learning. We don't learn any of this stuff in medical school.
No,
and certainly
we don't.
nobody's teaching me any of this stuff. I luckily have, you have your husband, and my 19-year-old is like in college from his bedroom here in my house. So he's my IT help desk. But outside of that, you know, I think we're all kind of just try to fumble through it a little bit too. But once you learn the technology, I think it can be applied to connect with other people too. And so the last few minutes I wanted to just spend, Jill, thanking you for your advocacy, but also getting a sense, because you've been a Parkinson's doc now for, it sounds like 10 years.
Yeah.
You have been resilient in your own way of, you know, we've talked about these different bumps in the road and how you've kind of, rather than just being like, oh, well, you know, not going to be able to do this or that, like give up, you know, finding solutions. How do you kind of keep positive? How do you kind of keep hope in your patients? And what do you think are sort of, I know we really connect on some of the lifestyle wellness kind of strategies. Maybe in the last 7 minutes we have here, teach us a little bit about what you think are the secrets that you have, you know, taught your patients that help them, you know, with that resilience, help them keeping hope, and who does the best, you know, in terms of the lifestyle stuff.
Yeah, no, so I think it's extremely important. And one of the things that I tell my patients all the time is you can't disentangle mood and movement symptoms. So mood plays such a huge role. And whenever I speak to a patient or I'm talking to them about the whole approach, you know, mind, body, everything that goes into that connection, I never want to belittle. So I never want to make anybody feel that the concern that they're coming to me is, you know, not high up on a tier of importance, because clearly it's important if you're bringing it up and you're mentioning it to me. So I try to validate what my patients are saying and what their concerns are. But then I'll also try and flip it on its head if I think that the perspective in which they're talking and bringing it to me is one-sided in that it's their side and it might have a negative spin because of the context of everything else that's going on. And I try in a ginger way not to make everything seem like it's, you know, roses and rainbows, but to say, well, have you thought about it like this? Or have you been able to look at the things you are still able to do? Are you able to consider participating in X, Y, or Z activity that might be able to help change your perspective? Because perspective is so important. And I try to instill that if you, everybody can have their good days and bad days, but if you are have the tendency and the notion to be more of a glass half empty instead of a glass half full kind of person, then that's going to have an impact on your outlook and the trajectory of your Parkinson's symptoms. So if we can try and help you transition over into a little bit more of a positive perspective, then that will pay dividends going forward. And then there are articles about that, and not sciencey ones, you know, ones from magazines and New York Times and things that talk about mindfulness and perspectives and well-being, that I try to, you know, provide to my patients so that they don't just think it's me that's talking about it. But I think that focusing on an attitude shift or a perspective change is really important if we're not getting there in another way. Like if just trying and talking through the usual routine of the meds that need to be adjusted and the exercise that I'm trying to get you to do, or the physical therapy or the other types of therapy that I'm trying to get you to participate in, if it's not working and we can't quite figure out why, then we kind of delve a little deeper into the perspective part and the mood part of things. It's sometimes a touchy subject, but I try, again, getting back to that bedside manner and making it a judgment-free space. I try to do it in a respectful and a ginger way, but sometimes they're difficult conversations that you have to have. But I think that they are necessary ones. And I would say that for the most part, people are receptive to it. And it's not a one and done conversation. It becomes an ongoing dialogue. And then there are some days where we all just have pity parties and it is what it is. And then the next time we just try and do better.
So sort of reframing and pivoting.
Yes, reframing and pivoting. Mm-hmm.
Yeah. And how about from a lifestyle perspective, Jill, as a doc who's taking care of Parkinson's patients, are there like maybe 2 or 3 things you tell all of your patients to try to do on a daily basis, especially with the pandemic that has been,
I stick to a routine. That's one thing. Routine is huge. Get some sort of physical activity in during the day, even if it's not overly vigorous. Like if you can't get outside to go walking, or you can't do that, even if you can do something in your house that is an activity, whether it's a virtual dance for PD program or a virtual boxing program or a virtual big program, or just something that is that can get you, even it's just stretching, that can do some sort of physical activity. So make that part of your routine. And as like part of, again, I think the thing I stress most is routine, because people were like, I wake up whenever and I don't get dressed and I don't do anything. So stick to a routine, do some sort of physical activity, and take a shower and get dressed every day. Like that, I think at the bare minimum, at least puts you into a better perspective of, again, that perspective of being able to tackle the day.
Absolutely. And I know that you and I have connected a little bit through some virtual mediums, just to have a happy hour here and there with some of the women in neurology group. And I think, you know, even as clinicians and as docs who have houses full of people, and, you know, we're sort of surrounded by patients all day long, I think the social connection that we have formed, you know, with that, you know, in a space that can kind of connect us through a purpose and help us kind of get through this pandemic has been lovely, I would say, you know, just women in neurology. And I think I would say to urge patients to continue to try to find, you know, people in their worlds that they can socially connect with. I think it can be very nourishing and kind of help hugely through the pandemic. And, you know, sort of even if you feel like you're in a nursing home or in a place that is surrounded with people, if you're not connecting with them and really sharing, you know, stories and common, you know, sort of stressors or whatever, and finding, you know, somebody to confide in, it can be very lonely. So I think, you know, having this with the women's group has been lovely for me. And I urge people to try to do that. And just showing up with this space space. And I want to give a shout out to the PMD Alliance. I think you guys have spent a lot of time and energy, which I have no idea how you have the patience to do this, because I know with the IT issues with my own parents, trying to get them on a weekly Zoom call with us has been interesting. So I really do think that the kudos to you guys who are literally spending the time to try to educate our patients and people who are out there to connect in this virtual space has been really amazing. And Cookie does say that seniors need education on how to use all these apps and stuff too. I mean, I do think that there's so much at our fingertips, but I think there's almost I do notice sort of a frustration and a fear and sort of this anxiety around all the things that are being possibly missed because of this lack of tech savviness. And so I think, low hanging fruit would be, getting people access to internet that's affordable or free, and then teaching them how to use this in some very basic way that they have access to. And I don't know exactly if it would be, harnessing the power of all the, the teenagers that are maybe not doing other things with their time and trying to get them connected. I don't know, but, having some way to teach people is really, really important. So anyway, well, thanks again to you, Jill. So lovely to see you.
Thank
And happy
you. You too.
birthday.
Thank you.
And then thank you to the gang at the PMD Alliance. I'll pass it back to you, and we'll link all this stuff. And Jill, definitely give us some links where patients can advocate for the telehealth, because I do think that's also something that's important.
Awesome. Thanks, everybody.
Yes.
Bye.
So we'll send you on to your weekend with a thank you, goodbye wave, Dr. Farmer. If you want to scroll through people all across the country and
I
the
love
world.
it.
Thank you for joining
that's
us.
amazing.
Thank you to both
Of
doctors
course.
for all you do.
Thank you.
Bye now.
Bye.